So good morning, everyone. So today in the continuation of uro-oncology. So today we are going to start the testicular tumors. So today we will be discussing the basics like just go through about the anatomy and their blood supply, something about epidemiology and the evaluation of patient with testicular tumors. So we will be discussing the management in the later lectures. So today we will be discussing just the introduction and evaluation in a patient with testicular tumors. So that's that.
Good morning. My name is Dr. Zoha. Today I'm going to be presenting my lecture on introduction to testicular cancer. So the objectives of this presentation is that we are going to learn the epidemiology, etiology, classification, clinical features, investigation, and staging of testicular cancer. So let's just skim through the anatomy of the testis first. The testis is the male gonad. It is homologous with the ovary in the female. It lies obliquely within the scrotum, suspended by the spermatic cord. The left testis is slightly lower than the right. Its shape is oval. It's 3.75 centimeter long, 2.5 centimeter broad, and 1.8 centimeter thick. It weighs around 10 to 15 grams and has two poles, two surfaces, and two borders. The covering of the testis includes the skin, dartos muscle, external spermatic fascia, cremasteric muscle between the two fascias, tunica vaginalis, and tunica albuginea. The retitestis, as you can see in the diagram, is the network of tubules located in the hilum of the testis that carries sperm from the seminiferous tubules to the efferent ducts. Retitestis gives rise to 12 to 30 efferent ductules. Epididymis is a tube about 20 feet long that is coiled on the posterior surface of each testis, connects efferent duct to vas deferens. The ductus deferens extends from the epididymis in the scrotum on its own side into the abdominal cavity to the inguinal canal. The blood supply of the testis is by the testicular artery, which originates from the abdominal aorta. The testis also has extra blood supply collaterally from the cremasteric artery and the artery to the ductus deferens. The venous drainage of the testis is that the veins emerge from the back of the testis and receive tributaries from the epididymis. They unite and form convoluted plexus called the pampiniform plexus. The plexus to form a single vein which opens to the right side into the inferior vena cava, on the left side into the left renal vein. The primary drainage of the right testis is within the interaortocaval region. The left testis drains into the para-aortic region in the compartment bound by the left ureter, the left renal vein, aorta, and the origin of the inferior mesenteric artery. The crossover of lymphatics from the right to left is possible.
What is the importance of this lymphatic drainage in testicular tumor? Why it drains in the pre-aortic and para-aortic region? Why not in the inguinal region? Although the testis lies very near to inguinal canal and inguinal region. So why it's important to know about this?
In malignancy like in testicular carcinoma, if we want to do retroperitoneal lymph node dissection, so we should know about the lymphatic drainage of the testis.
Introduction to testicular tumor. These testicular tumors are rare. 1 to 2% are malignant tumors. Most common malignancy in men are from the age group of 15 to 35 years. Benign lesions represent a greater percentage of cases in children than in adults. It's one of the most curable solid neoplasm. There are 3 peaks of testicular tumor. First is from age 2 to 4, second is 20 to 40, and the third is above 60 years. Testicular cancer is one of the few neoplasms associated with accurate serum markers. It is one of the most curable solid neoplasms and serves as a paradigm for the multimodal treatment of malignancies. So going on to the epidemiology of testicular cancer, the most common is between ages 15 to 55. It increases, there is a rapidly increased rise after puberty, peaking at age 25 to 35. The incidence varies greatly according to the geographic region. Rates are highest in Scandinavia, Western Europe, New Zealand, Australia, intermediate in USA and UK, and lowest seen in Africa and Asia. The etiology of testicular tumor. So one of the main causes of testicular tumor or risk factors, as you can say, is cryptorchidism, intersex disorder like Klinefelter's, testicular atrophy. Trauma prompts medical evaluation, chromosomal abnormalities like loss of chromosome 11, 13, 18, abnormal chromosome 12p. Sex hormone fluctuations, estrogen administration during pregnancy, race, carcinoma in situ, and previous testicular cancer. So the classification of testicular cancer includes 3: primary, secondary, and paratesticular neoplasm. Primary tumor is divided into germ cell tumor and non-germ cell tumor. Non-germ cell tumor includes Leydig, Sertoli, gonadoblastoma, adenocarcinoma of retitestis. The germ cell tumor is broadly classified into seminoma and non-seminomatous. Non-seminomatous is further classified into teratoma, embryonal carcinoma, choriocarcinoma, yolk sac tumor, and mixed tumor. The type of germ cell tumors include seminoma, embryonal carcinoma, teratoma, which includes mature and immature, choriocarcinoma, yolk sac tumor, and spermatocytic tumor. Non-germ cell tumor, again, I would like to tell you that it is specialized gonadal stomal tumors, gonadoblastoma, and miscellaneous. Specialized gonadal stomal tumors include Leydig and Sertoli, gonadoblastoma alone, and miscellaneous includes carcinoid tumor and tumors of ovarian epithelial subtypes. Germ cell tumors is most common in young age group. There is rapid rate of growth and good differentiation is seen. It is both sensitive to chemotherapy and radiotherapy. It has good prognosis because of its response to both these palliative treatments. Germ cell neoplasm in situ. With the exception of spermatocytic tumor, post-pubertal invasive germ cell tumors arise from germ cell neoplasm and neoplasia in situ. It consists of undifferentiated cells that have appearances of seminoma located basally within seminiferous tubules. Seminoma is the most common testicular tumor. Its peak incidence is 4th and 5th decade. Patients present with a painless testicular mass. It stains negative for CD30 and positive for CD117 and placental alkaline phosphatase. Serum AFP is normal. Macroscopically, there is a soft tan to white diffuse multinodular mass. Microscopically, it has sheet-like arrangements of cells with polygonal nuclei and clear cytoplasm, with cells divided into nests by fibrovascular septa that contain lymphocytes. Since cytotrophoblasts which stain positive for HCG can be identified in 15% to 15% of the cases. Spermatocytic tumor, which was previously included in seminomas, is a benign tumor with peak incidence of 6 decades of life. Unlike other GCTs, does not arise from germ cell neoplasm in situ and not associated with history of cryptorchidism. Histopathologically, it differs from seminoma that they do not stain for PLAP or glycogen stain. Microscopically, nuclei are round, minimal lymphocytic differentiation is seen. Moving on to embryonal cell carcinoma, it is the second most common germ cell tumor. Aggressive tumor, often with high rates of metastasis, often in context of normal markers. It is mostly undifferentiated type of non-seminomatous germ cell tumor with totipotential capacity to differentiate to other non-seminomatous germ cell tumor types within the primary tumor and metastatic sites. It typically stains for PLAP, AE1, AE3, and OCT3 and 4. Macroscopically, there's a tan to yellow neoplasm with often large areas of hemorrhage and necrosis. It varies greatly microscopically. Choriocarcinoma is a rare and aggressive tumor with 5-year survival of 5%, typically elevated HCG, presents as a disseminated disease. It metastasizes most commonly to the lungs and brain. It is primarily very small and often exhibits no testicular enlargement. A small palpable nodule may be present. It is very prone to hemorrhage, sometimes spontaneous, in lungs and brain both. there is catastrophic hemorrhage immediately after chemotherapy sometimes. Macroscopically, it is a primary lesion, maybe hemorrhagic or a clotted mass in which bits of gray tumor can be seen. It presents as nodules, as previously mentioned. Microscopically, it consists of both in situ trophoblast and cytotrophoblast, and prominent areas of hemorrhage and necrosis can be seen. Yolk sac tumor is most common germ cell tumor in children and most common testicular tumor as well, where it occurs in its purest form. In adults, it is unusual in pure form, but is found approximately 50% of mixed germ cell tumors. Testicular mass is the most usual presentation that is found in this tumor. It almost always produces AFP and never HCG. It is easily detectable and has lower relapse. Macroscopically, it is white to tan masses with myxoid and cystic changes. Microscopically, there's a reticular network of medium-sized cuboidal cells with cytoplasmic and extracytoplasmic eosinophil, hyaline-like goblets, glandular papillary or microcystic pattern, and Schiller-Duval bodies are its characteristics. So the teratoma in Greek means monster tumor. Occurs in its purest form with a mean age of diagnosis at 20 months. In adults, it occurs as a component of mixed germ cell tumor and is identified in more than 47% of mixed tumors. Pure teratomas are uncommon, and serum markers that are elevated is AFP, which is mildly elevated. Macroscopically, it largely depends on elements within it with solid and cystic areas. Microscopically, it contains more than one germ cell layers, which includes ectoderm, endoderm, and mesoderm, range from mature with well-differentiated tissue to immature with undifferentiated primitive tissue. It is composed of somatic type of tissues that include enteric type glands, respiratory epithelium, cartilage, muscles, and hair. Immature teratomas contain immature neuroepithelium, blastema, or cellular stroma. It can give rise to carcinoma such as adenocarcinoma, sarcoma such as rhabdomyosarcoma. So two types are growing. Growing teratoma syndrome is may grow uncontrollably, invade the surrounding tissue, and is almost mostly unresectable. Teratoma with malignant transformation, as previously mentioned, is rarely teratoma may transform into a somatic malignancy such as rhabdomyosarcoma, adenocarcinoma, or primitive neuroectodermal tumor. So the signs and symptoms in testicular tumor is that the most common symptom is painless testicular mass. Acute testicular pain is caused by intratesticular hemorrhage or if there is an infarct. The patients may complain of vague scrotal discomfort or heaviness. Symptoms related to metastatic disease are presenting complaint in almost 10 to 20% of these patients. Bulky retroperitoneal metastasis may cause a palpebral mass, an abdominal pain, flank pain resulting from ureteral obstruction, back pain cause of involvement of psoas, muscle, or nerve roots. Pulmonary metastasis may present with dyspnea, chest pain, cough, or hemoptysis. Approximately 2% of men have gynecomastia resulting from either elevated serum HCG levels, decreased androgen production, or increased estrogen. Physical examination in testicular tumor includes the examination of the affected and normal contralateral testes, noting their relative size, consistency, and palpating any testicular or extratesticular mass. Atrophy of the affected or contralateral testes is commonly particular in patients with cryptorchidism. Any firm area within the testes should be considered suspicious for malignancy and should prompt further investigations. Examination for evidence of palpable abdominal mass or pain, inguinal lymphadenopathy, gynecomastia, and supraclavicular lymphadenopathy can be found. Differential diagnosis in a patient with testicular cancer can be epididymoorchitis, torsion, hematoma, paratesticular neoplasm, hernia, varicocele, spermatocele, and a firm intratesticular mass should be considered cancer until proven otherwise.
So, residents, please, if the patient present to you with a painless testicular swelling, so how will you perform your examination and make your differential out of them? So, what should be your protocol? What should be the examination protocol? You, Najib, क्या एग्जामिन करेंगे? क्या आपके जहन में होगा कि आप क्या देखना चाह रहे हैं? एक पेशेंट आ गया पेनलेस स्क्रोटल स्वेलिंग के साथ कि मुझे 15 डेज से फील हुआ है कि मुझे एक स्वेलिंग हो रही है, देन हाउ विल यू प्रोसीड?
Examine the patient. Steps of examination. First, we will do inspection, palpation. By inspection, we will see any skin changes like erythema or any inflammatory changes, any redness, and we can estimate the size of swelling, whether it's bilateral or unilateral. After that, on palpation, we will see whether it is tender or non-tender. We will do examination and we will see whether we can get above the swelling or not. After that, we will examine abdomen for any intra-abdominal we can palpate any intra-abdominal swelling or not.
Anything else? और क्या करेंगे? और एग्जामिनेशन में कोई इम्पोर्टेंट एरिया? ओके, डन. हाँ, स्टैंडिंग पोजीशन में देखेंगे. और ठीक है, आप क्या देखना चाह रहे हैं अपने पल्स में? हर्निया से डिफरेंशिएट करना चाह रहे हैं, और कुछ इसके अलावा?
We will elevate plain signs, elevate the testis. If it will cause pain or the pain increases, then
so it's painless swelling. The patient already presented with a painless swelling. So, और क्या एग्जामिन करेंगे? कहाँ जाके ड्रेन करते हैं? Yes, the supraclavicular lymph nodes are very important to examine for. In chest examination is very important. Testicular tumor कहाँ metastasize करता है first? कहाँ जाता है? Lungs are the most common site for metastasis of testicular tumor. So how will you differentiate a testicular tumor from epididymitis, hydrocele, and hernia? क्या features होंगे on examination? Yes, long history of testicular mass में long history होगी, ठीक है. hernia में short होगी. Does age differences matters? Age matter करती है? अगर एक patient है 30-year-old male present to you with a painless testicular swelling for last 1 month, what's in your mind? क्या होगा?
Sir, again we will suspect testicular neoplasia.
अगर एक 30-year-old male है, आता है, एक महीने की हिस्ट्री है, पेनलेस स्वेलिंग है, क्या आपके माइंड में क्या आएगा? हर्निया, हाइड्रोसील, क्या आएगा?
ट्यूमर ही आएगा सर, फर्स्ट
ट्यूमर आएगा. और कोई? और कौन सा ट्यूमर सस्पेक्ट करेंगे? अब ये यंग बंदा है 28-30 साल का, तो क्या लगेगा आपको? यस, नुमान.
So this was written somewhere. Whenever there is a testicular swelling, until unless proven it is a tumor.
History and examination is very important. As a part of your examination, you always have these patients in your short case. This topic is very important for your exam point of view. So always you must have these patients in your short case, always in your exam. और एग्जाम में यही होता है कि आपको शॉर्ट केस मिलता है, एक शॉर्ट कमांड मिलती है. यस नुमान.
So testicle, whenever the patient present with to us with a testicular swelling, either it is a painless or it is a painful. It is a tumor until unless proven otherwise. And number two, there you have asked the question regarding what is the difference between hydrocele and the tumor, how to differentiate. This is the basic test which we have studied in the third year of MBBS. During the hydrocele, you can see the swelling, you can get above the swelling, and the most important thing, you can see through the swelling, transillumination test in a dark room and X-ray in our hand. But in a testicular tumor, it was written mostly that it is a painless swelling, but it can be a painful swelling if it is having an infarct in it, or it is compressing the capsule or the structures. And number third, the swelling, it can be at any pole of the testis. It can be the mid of the testis.
Transillumination क्या positive मिलेगी negative मिलेगी?
In testicular tumor, hydrocele, it might be the presenting complaint in some patient. We cannot miss the hydrocele relating to the
अगर
testicular.
testicular tumor है तो उसमें positive मिलेगी या negative मिलेगी?
If
Transillumination.
If hydrocele is a presenting complaint, and on the color Doppler, and you cannot palpate the whole testis, and you cannot palpate the node, nodule, or nodularity in the testis, but on doing ultrasound of scrotum with color Doppler imaging, you see the heterogeneous foci, hypoechoic foci. You can then you have to rule out that this hydrocele. Sir, अगर हाइड्रोसील प्रेजेंटिंग कंप्लेन हुई तो पॉजिटिव मिलेगी टेस्टिकुलर ट्यूमर में.
It's not. If there is a intratesticular hemorrhage and there is a testicular mass, but there is a reactionary fluid due to tumor. So if there is a fluid around the tumor and around the testes with the testicular mass, you may find the transillumination positive in these patients. It's not always, but most of the time it's negative, but you may find the positive transillumination in patient with the reactionary fluid collected around the tumor. लेकिन सवाल वही रह गया कि डायग्नोसिस क्या होगा आपका, क्या सस्पेक्ट करेंगे? 30 ईयर में क्या होता है?
जर्म सेल
ट्यूमर. तो कौन सा जर्म सेल ट्यूमर सस्पेक्ट करेंगे? नॉन सेमिनोमेटस. तो अगर ये मैं कहता हूँ यही पेशेंट है और इसी तरह का उसकी एज जो है वो 60 इयर्स है और वो आता है बायलेटरल टेस्टिकुलर स्वेलिंग के साथ.
After 50 years, germ cell tumors are less likely. There might be the non-germ cell tumor like lymphoma or leukemia.
क्या सस्पेक्ट करें? इसी आवाज आई लेकिन yes, lymphoma is the second most type of testicular tumor in those patients who are more than 50 years, presenting with particularly with the bilateral testicular swelling, but can present with the unilateral testicular swelling. और हाइड्रोसील किया आपने, अगर किसी को पैराटेस्टिकुलर नियोप्लाज्म है और टेस्टिकुलर स्वेलिंग से कैसे डिफरेंशिएट करेंगे आप ऑन क्लिनिकल ग्राउंड?
On clinical ground, we can during the examination or during the inspection, it can look like there is two swellings. You can see that the lower one is a testis, another one is another region. But on palpation, while you are palpating the single testicular same time, you can palpate the testis separately and the paratesticular mass in the epididymis or in the spermatic cord separately. And you can confirm it on ultrasound later on.
Sometimes you find 3 testes. आपको ऐसा लगता है कोई 3 testes है, but it's not always. There is something with. Zoha?
Thanks, sir. Dr. Zoha very well documented and presentation. And in the seminoma, there are no tumor marker, and there are no reason tumor marker. But as she said that in some tumors, testicular tumors, only seminoma component, you can have the syncytial trophoblastic component on a histopathology. So in 10 to 15% of seminoma cases, you have the raised beta HCG level also. But in seminoma, you can have beta HCG level raised. So
usually tumor markers are not raised in a seminoma, but in non-seminomatous disease is always a rise in tumor.
Is always having a raised tumor marker. Like if it is a pure yolk sac tumor, you see the raised AFP level. But in CHORIOCARCINOMA, you have the beta HCG level. But mostly we see the mixed germ cell tumor. We have the 3 beta HCG and AFP level, both are raised. And LDH is just the tumor burden. It can be raised in seminoma and non-seminoma. Seminoma, this is a
question is why is that pure seminomas don't have raised markers and other tumors have raised markers?
Seminoma, you find a spermatocytic. This is a region from spermatocytic cells, not the differentiated cells like chorions, and in yolk sac you don't have the cells who produce the AFP. It is an undifferentiated form of the cells. When the cell is a differentiated, it can produce its related product like AFP, beta HCG. But in seminoma, the cells are not differentiated.
Should I continue? Yeah. So basically, there's diagnostic delay in testicular cancers as well. And it is called, prior studies show up to 1/3 of testis tumors are initially misdiagnosed as epididymitis and hydrocele. For patients with metastatic signs and symptoms, these may be the focus of the physician treating the patient. The interval of delay is associated with advanced clinical stage, suboptimal response to chemotherapy, and diminished survival.
So it's usually in a young patient who has a painless testicular swelling, it's not being delayed much in these patients. But if a patient with a more than 50 years present with the testicular swelling and it's sometime painful and sometime painless, and ultrasound does not pick out the disease or some focal lesion, then you can have a diagnostic delay definitely in those patients. I don't have seen any of patient who has this type of 50-year or diagnostic delay. Have you seen, sir? So yes, sir. Have you heard any experience of the patient who in a clinic that more than 50 years ago?
Yes, there is another variant, and that is known as Sartori cell only tumor, and sometimes it is missed whenever a test is taken out if the histopathologist is not familiar with it. And this Sartori cell only tumor has got slight bit of higher frequency in bimodal pattern. First of all, it appears before 20 years of age, and the second surge is after maybe 50 to 60 years of age. So in our series of orchiectomies in this unit, SIUT, we have got a quite substantial number of cases in both the groups, in early group as well as in the later group. So anybody who wants to practice this field has to be familiar with this kind of pattern. So it's not always the case that anybody who is 50 years plus will not have anything in the scrotum which tells you that it is something of malignancy. So malignancy can happen, but the variant is different.
So the investigations that for testicular cancer include scrotal ultrasound, magnetic resonance imaging, serum tumor markers, and radical inguinal orchiectomy.
So the tumor markers are used only for the diagnosis, या और भी कोई reason है क्यों इस्तेमाल करते हैं tumor markers? Follow up कर सकते हैं और क्या करते हैं? Response to treatment, yes. और yes. Or recurrence. So it's not only for the diagnosis purpose, but you need to follow your patient with the tumor markers for various reasons, for the recurrence, relapse, your treatment response, and the follow-up.
So scrotal ultrasound in men with a testicular mass, hydrocele, or any unexplained scrotal symptoms, scrotal ultrasound should be considered an extension of physical examination. With high-frequency transducers, intratesticular lesions are as small as few millimeters can be identified and be distinguished from extratesticular pathology. Typical germ cell tumors is hypoechoic, and 2 or more discrete lesions may be identified. Heterogeneous echo texture within a lesion is more commonly associated with non-seminomatous germ cell tumors. The risk of malignancy increases with the size of the lesion from 50% to lesions smaller than 1 centimeter and 80% for lesions 1 to 2 centimeter. MRI. In cases in which the sonographic findings are equivocal or suboptimal, MRI is a helpful tool to distinguish between testicular versus extratesticular lesions and neoplastic versus non-neoplastic lesions, as illustrated by the diagram. So serum tumor markers, one of the few malignancies which is testicular tumor, is associated with serum tumor markers. The tumor markers include LDH, AFP, and beta HCG. Serum tumor markers should be obtained at the time of diagnosis after orchiectomy to monitor for relapse in patients on surveillance and after completion of therapy. So as the chart shows, seminoma may variably or might have beta HCG positive or LDH positive. Yolk sac tumor almost always has AFP raised and might have beta HCG or LDH. Choriocarcinoma has almost always beta HCG raised and sometimes LDH. Embryonal carcinoma mostly has LDH raised and less likely AFP and beta HCG. Teratoma has no tumor markers. Please, sir.
Subunit of beta HCG बार use. I'm not clear. Subunit of beta HCG. टेस्ट के लिए जो लिख रहा है पेपर में, तो ये इसका क्या मकसद है? सेम ही है beta HCG. Subunit of beta HCG.
I don't know whether it's some isomer of this beta HCG. Noman, do you know of it? Because this is part of your thesis.
It is a beta HCG is a dimer. It has two components, alpha subunit and beta subunit. It consists of the amino acid numbers. As far as I remember, the alpha is 95 and beta is about 180. I am not correctly saying, but casually. So the beta is, this is a dimer consisting of the amino acid chains, which have two components. One is having about 180 and one is having the about 90 amino acid in it. And in testicular germ cell tumor, the tumor marker which has been studied is the beta unit of HCG dimer. So we see when we request the beta HCG to our lab, they do the beta HCG because we are concerned with the beta HCG only. This part of dimer, amino acid chain.
मुश्ताक कुछ कहना चाह रहे हैं मुश्ताक कुछ कहना चाह रहे हैं
Because the alpha subunit is common in the TSH and FSH. So if TSH is also raised and we just request an HCG or alpha HCG, then it can give a wrong impression. So in testicular tumor, we typically measure the beta HCG.
So it is like two alpha and beta. So the beta is the subunit, the other subunit is the alpha. So alpha is HCG and beta HCG. So Mushtaq is correct. Thank you very much.
Thank you.
So first is AFP, which the normal value of AFP is less than 16 nanogram per ml. Half-life is 5 to 7 days, and raised AFP is seen in embryonal carcinoma, teratocarcinoma, and yolk sac tumor. HCG, which is beta, is the normal value is less than 1 nanogram per ml. Half-life is 24 to 36 hours, and raised beta HCG is seen in choriocarcinoma, embryonal carcinoma, teratocarcinoma, yolk sac tumor. LDH is expressed in smooth cardiac and skeletal muscles. Its half-life is 24 hours. It is elevated in approximately 20% of low-stage germ cell tumors and 60% of advanced germ cell tumors. Result of tumor markers assays should not be used to guide decision-making about whether to perform a radical orchiectomy because AFP or HCG levels in the normal range do not rule out germ cell tumors. Radical inguinal orchiectomy. Suspected testicular neoplasms should undergo radical inguinal orchiectomy with the removal of tumor-bearing testicle and spermatic cord to the level of inguinal ring. It establishes a histological diagnosis and primary T stage provides important prognostic information from tumor histology.
Yeah, I बात तो इसलिए मैं पूछ रहा हूँ. What is the difference between a radical inguinal orchidectomy and a regular orchidectomy, and why do we do it like this in case of tumors? That is the question.
When you have a suspicion of the testicular tumor, you on ultrasound and after confirmation of the tumor marker, when you have the diagnosis that this patient has a testicular tumor, you do the radical orchidectomy from the inguinal incision, not while we do the normal orchidectomy, we do the testicular incision, the median, paramedian, or transfer incision. But in tumor, we do the radical because we don't want to violate the we don't want to have the scrotal violations. This can the testicular tumor usually drain through the lymphatic channel to the retroperitoneum and lungs and supraclavicular and sometimes to the brain. So while doing the scrotal violation, we can have the seeding to the skin channels of the lymphatics, and it can also go beyond the inguinal lymph nodes. So to avoid this seeding, you do the radical orchiectomy via the inguinal incision and just clamp the cord and remove the whole testis from it.
So the next question is, where does this skin of the scrotum drains? And the other one, that is, you have already mentioned the testis. So it goes up, rather it falls where the testicular vein falls, and that is at the level of interaortocaval area. The second thing is inguinal ring. So there are two types of inguinal ring, or two positions of inguinal ring. One is the superficial, the other one is the deep ring. So where do you want to have it? The cross clamping, deep or superficial?
कहाँ से आती है? कहाँ से आती है?
कहाँ तक आप लेंगे इसको? आपकी पिछली स्लाइड में आपने सिर्फ इंगुइनल रिंग लिखा था. पीछे चलिए. ये बल्कि इसमें लिखा हुआ है, ये लिखा हुआ है. To the level of inguinal ring. So superficial or deep? बता दें, कोई भी बता दे.
बता दें भाई, क्या हो गया?
Superficial.
Clamp the cord. We could do the cross clamping from the superficial ring if we can approach inside the canal, but it is difficult because once it is retracted beyond, we cannot pull back to the from canal to outside and reclamp it. A direct branch of testicular artery is there. So mostly we do the clamping just near the superficial ring if the mass is not extending beyond it.
To my understanding, the cord has to be taken up to the deep inguinal ring. So you have to have as close to the deep inguinal ring as possible. It's not the superficial ring. Okay, so go back and read it again.
नोमान के अलावा भी लोग बैठे.
It's not as simple as doing it because it's a 5 minutes job if you know it. But if you don't,
the cord first.
नोमान के अलावा
अब्दुल रहमान.
सब पता है, सब बोले, कोई मना नहीं, कुछ भी बोले.
Sir, for the staging purposes,
हाइट बात है, सब कुछ ज्यादा.
for T staging, temperature.
सर आप कुछ बोल रहे हैं?
Clamp it before disturbing the testis, so that there is no venous seedling proximally through the venous channel. So you clamp it, then you handle the testis and remove it. For going through this inguinal approach for this orchidectomy is that in case if you want to go for radiation, so if you go through the scrotal incision and you want to radiate that area from which you have taken out the testis, and the second testis will be affected by that radiotherapy, and that will result in decreased number of spermatozoa and other complications that can result from it because of that radiotherapy. So you want to avoid any different damage to the other testis.
Thank you, sir.
but we have got two cases in our series in which the other testis, which supposedly was a normal testis, it was intentionally moved from the original place and put into the inguinal area, so that the scrotum is available for the radiation to be applied. So we have done it in 2 of our cases. And after the radiation therapy, what happened was the scrotal sac was crumpled, and not only crumpled, is squeezed. So there was no space available so that you can do occupexy later. So what then was done was actually making of a space within the scrotal sac, and then successfully the other normal testis was taken back from the inguinal area to the scrotum. So this is the kind of maneuver that you as a urologist will be asked to do by your friends from the radiation oncologist. So we have to respond to it. It is very important for everybody of us to know the anatomy clearly, because this job will be done by us, nobody else, not the general surgeons. So if they ask you to do it, then you have to do it, provided you know the anatomy, right? You can do it. You can do it wherever you want to have it. But the longer you displace it, the difficult will be to replace it into the scrotum. So make it as close to the scrotum as possible. So the inguinal region is very close. The medial side of the thigh or the abdominal wall, the lower abdominal wall, is available to you. But then when you replace it, it will be difficult for the testis to move down, because it will be, your blood supply will be in tension. So couple of times this was done, and both of the times this was thinking at the back of the mind that the longer we took it, the difficult would be later to replace it.
The clinical staging of testicular tumor includes that.
Is there any role of frozen section?
No, sir. Okay, this was done just because the reason that the oncofertility problem has to be addressed, because these are all young people. They want to preserve the fertility potential. So either you have got the sperm banking and things like that when you want to destroy both the testes. But if you want to save it and you don't have the facility, which we don't have it as common as it should be, so we do these kind of things. Again, for frozen section for two purposes. One, frozen section is to know where the lymph nodes are. The lymph nodes are positive or not. That's something different. But for frozen section, to know where the actual surgical margin, positive or negative, is, I think it was never done in this kind of case.
This paper is mentioning that by frozen section you can save many testes, and this paper mentioned that in those cases where nodules are not palpable and you have opened it by suspicion on ultrasound, so in those cases you should go for frozen section. You can save testes.
It was about the testis preserving techniques.
If it is solitary,
Maybe, but
It's a partial orchiectomy. It's not the complete orchiectomy.
paper is emphasizing on frozen section.
This was about partial.
Maybe.
Yes, sir.
particularly in a solitary, if a tumor in a solitary testis, then we should go for otherwise prefer for radical orchidectomy.
So prognosis and initial management decisions are dictated by the clinical stage of the disease, which is based on histopathological findings, pathological stage of primary tumor, post-orchiectomy serum tumor marker levels, and presence and extent of metastatic disease. The clinical staging of abdomen and pelvis can be done by CT scan easily. CT imaging with oral and IV contrast is the most effective, non-invasive means of staging the retroperitoneum and pelvis. It is consistent 25 to 35% rate of pathologically involved retroperitoneal lymph nodes and has been a normal CT scan. A size cutoff of 10 millimeter is frequently used to identify enlarged lymph nodes. Retroperitoneal lymph nodes 5 to 9 millimeter in size in the primary landing zone should be viewed with suspicion for regional lymph node metastasis. Malignant germ cell tumors accumulate FDG, and several studies have investigated FDG PET scan in the staging of GCT at diagnosis and assessing response after chemotherapy. So as you all know that testicular tumor metastasizes to the lungs. All patients with GCT should undergo chest imaging before management decisions.
And slide says platin.
Talking about the CT of the chest, why do you need to assess the CT chest for looking for a GCT there?
Extra testicular germ cell.
Sir, you are rightly saying this is due to the regeneration of the testicular tumor. It can usually it is a testicular tumor, but germ cell tumor have three sites. Number one is a testicular Number 2 is the retroperitoneum. Number 3 is the mediastinum.
So always CT chest, or in some cases X-ray chest first. Yes, X-ray chest first with CT abdomen and pelvis. If there is suspicion, or you are suspecting clinically, then you go for CT chest.
Thank you, sir. So thoracic metastasis in the absence of retroperitoneal disease or normal serum markers is uncommon.
Suppose if the serum markers are not normal, they're abnormal, and you don't find anywhere the germ cell tumor, the scrotum that is normal, there is no palpable mass in the scrotum, there is nothing in the chest. So what comes into your mind? So the next thing should be the extragonadal germ cell tumor. Now the extragonadal germ cell tumor can happen anywhere. And there is no area that can be spared. And I can give you an example from our series of SIUT series, where even a person coming with twice, once the person comes to us and he lives very close nearby, he is actually an owner of a pawn shop. So he came to us with a pyonephrotic kidney, and we just removed the kidney, and that was in the late 90s. It was a pyonephrotic kidney and nothing else. Second time he came to us with swelling of the eye. So we referred him to the ophthalmologist, and he was put under some medications, but later that eye swelling was converted into thysis bulbi. The eye ball was actually gone. So what they did, they scooped out the whole ball, and there was something at the retrobulbar area. So they biopsied it, and it came out to be extragonadal germ cell tumor. So extragonadal germ cell tumor behind the eyeball, it was never heard of, and that happened in, I think, 2008 or 2009. So anywhere, anything can happen. So if you happen to have these serum markers, your level of suspicion should be to look for somewhere something is happening. And the most important thing is you don't look for it, you treat for it. You start straight away with chemotherapy. You ask your colleagues from the medical oncology team, and on the basis of serum markers, they can decide what sort of protocol the patient should have. Because if you spend time in locating where the tumor is, it would rather waste the time and you would lose the therapeutic window.
Thank you, sir.
That's why histopathology is not always required in the patient with the strong suspicion of testicular tumor with the advanced malignancy. Sometimes in a high stage or in a stage 4 disease, you need to start with the chemotherapy. Let's wrap up.
So the presence of newly elevated and or rising serum tumor marker level after orchiectomy indicates the presence of metastatic disease, and these patients should receive chemotherapy. So according to the guidelines, serum tumor markers pre-chemotherapy staging is SX is when serum marker studies are not available or are not performed. S0 is serum marker studies are within normal limits. S1 is less than 1.5 times the marker, and HCG is less than 5,000. S2 is 1.5 to 10 times the normal range, and HCG is 5,000 to 50,000. S3 is more than 10 times the normal range LDH, or HCG is more than 50,000. The TNM staging of testicular cancer includes primary tumor, which is T stage, regional lymph nodes clinical, regional lymph nodes pathological, distant metastasis, and serum tumor markers as already mentioned. Primary tumor T stage would be PTX is primary tumor cannot be assessed. PT0 is no evidence of primary tumor. PTIS is intratubular germ cell neoplasia. PT1 is tumor limited to the testis and epididymis without lymphovascular invasion. It may include tunica albuginea, but not tunica vaginalis. PT2 is tumor limited to the testis and epididymis with lymphovascular invasion or tumor involving.
Time is over.
Thank you.